people get in. We're gonna give folks just a minute to get settled in as we just open up the webinar here. All right, so I've got 32 after and I see those the folks are trickling in there and whatnot. So we're gonna go ahead and get started. I'd like to welcome everybody today to our preparedness webinar series, our first one for this budget year, actually, on the impact of a regional disaster health response system during regional planning and response with Dr. Paul Billinger and Shelley Schwedem. This is just our description of it, talking about what we're going to be talking about today of our different regional disaster health response systems and everything. Here is our target audience, as well as some of our objectives that we're working with. We are offering some continuing education today to both physicians, or to all three physicians, nurses, and EMS, and we'll have information on how to do that both at the beginning here as well as at the end of the slideshow for anybody who would like to get the continuing education. Disclosure statement about the University of Nebraska Medical Center and our continuing education activities here, as well as disclosures that none of our presenters or anyone involved in this webinar today have anything to disclose in terms of financial interests or anything like that. For Q&A today, we do ask that you guys use the Q&A box located on the bottom of your screen there, and we will make sure that we answer those questions as best we can. If we do run out of time, then we will make sure that we gather any of those questions and answers and get them posted later on. For those of you who are going to be doing the continuing education portion of this, we ask that you use this portal right here. So you go in there and you evaluate the activity, use the code 57241, and that will get you set up. Again, this will be at the end of the webinar, so that you don't have to get that all at once. And that is the website for the continuing ed for those of you who need it. Real quick here, I'm going to stop share for just 1 second because I need to fix something. With no further ado, though, I want to introduce Dr. Paul Billinger and Shelley Schwedem. Dr. Paul Billinger holds the Massachusetts General Hospital Endowed Chair in Emergency Preparedness and is the director of the Center for Disaster Medicine and vice chairman for emergency preparedness in the Department of Emergency Medicine at Mass General. He's also the director for emergency preparedness at Mass General Brigham. Dr. Billinger additionally serves as the director of the Emergency Preparedness Research, Evaluation, and Practice Program at the Harvard T.H. Chan School of Public Health and holds appointments at Harvard Medical School and at the Chan School. Dr. Billinger serves as a special advisor to the Massachusetts Medical Society's Committee on Preparedness and serves as a medical officer for the Massachusetts 1 Disaster Medical Assistance Team in the National Disaster Medical System in the U.S. Department of Health and Human Services. Dr. Bittinger is an active researcher in the field of emergency preparedness and has lectured nationally and internationally on topics of preparedness and disaster medicine. He's authored numerous articles and book chapters on multiple topics related to emergency medical services and disaster medicine. Shelley Schwedel serves as the Associate Director for Clinical Operations and Emergency Management at the UNMC Global Center for Health Security. She also serves as the Executive Director of Emergency Management and Biopreparedness at Nebraska Medicine, with operational accountability for the Biocontainment Unit and National Quarantine Unit. She's also actively involved in the Omaha Metropolitan Healthcare Coalition and serves as the current chairperson of the Board of Directors. Shelley has previous leadership experience in perioperative services and emergency and trauma services. She's the program director and subject matter expert with the ASPR and CDC-funded National Emerging Special Pathogens Training and Education Center, or NETEC, and is actively involved in the activities of ASPR Training, Simulation, and Quarantine Unit, CDC Infection Prevention, and Antibiotic Stewardship. In addition to this, Shelley is involved in numerous federal, state, regional, and national grants, including our very own Region 7 Disaster Health Response ecosystem here at Nebraska Medicine. And with that, I am going to turn it over to you guys. I'm going to adjust a couple of slides while we're talking here, though. So go ahead and go if you would like there, Paul. I'm going to
Sure. I'll get started while you're working on that. So, thank you to all of you for attending. We're really excited to present the content here for you. Thomas, when you get a chance to put that in presenter mode, that would be great.
Yep.
We want to talk to you about regional disaster health response system structures, regional approaches, and Thomas, we're still seeing your edit.
Yeah, I know, that's why I've got to edit some of these transitions on me real quick.
Okay. We're going to both tell you about regional structures in general. We're going to tell you about our two programs, and we're going to use the experience of the RSV surge and what some people are calling the triple-demic with RSV, flu, and COVID to talk about some of the value the regional structure is going to have as an example. So that will really pave the way for where we think we would like to go together. But please do put your thoughts or your questions in the Q&A. We'd really love to hear from you. And we certainly would like to answer any questions you have. So next slide, please. Next slide. So let's talk about the value of regional structures. Why are we even thinking about regional disaster health response systems? What does this mean? I will first start with just a simple point of definition, that when we say regional in this context for this lecture, we're talking about a capital R region, meaning a multi-state region. Many people use the word regional with what we sometimes call a lowercase r, which is a sub-state region. Most all of our states are divided into regions. And in this case, we're talking about multi-state regions. And it starts with some of the information on this slide. Some of the disaster capabilities we need most in disasters, and that can be burn care, that can be trauma care, it can be inpatient pediatric care, pediatric critical care, pediatric trauma care. All of these clinical capabilities, which again, a lot of disaster events make us need, are not evenly distributed across hospitals, and they're really not evenly distributed across geographies. And so we end up really with sort of systems of haves and have-nots of who has access to these specialties. And what we really want is to make sure that the entire country has access to the necessary medical care and expertise to do as well as possible with any disaster event. It really is a challenge sometimes, even with access to tertiary care specialties or complex care hospitals. And what we need are systems that can better help collaborate among these kinds of specialty facilities. As you probably know, there really is no natural infrastructure across any of these capabilities. There's no 1-800 trauma number that unifies all trauma centers, or the same for burn, or the same for pediatric capabilities. And as Shelley and I will talk about a little later, was one of the big frustrations nationally during the triple-demic, that people were having to call pediatric hospital after pediatric hospital after pediatric hospital to find the right clinical resource for their patients. And we hope that we can slowly evolve to a system that is better. I will point out, just for those of you that don't know it, There are only about 300 burn surgeons in the entire country. And when you talk about a very small number of burn centers, a very specialized group of physicians, such as our burn surgeons, we have to make sure that we make the best use of this scarce resource in our planning and in our response. Next slide. So when would we use these kinds of regional resources, or what does it mean? Pretty obvious, I think, is a mass casualty incident. If we have a very large number of critically injured patients, even if you have a trauma center nearby, typically these events can overwhelm the closest trauma center. That was the case for us here in the Boston Marathon bombing. As we've tragically seen in numerous other events, including active shooter events, these events can get pretty big pretty quickly. Patients go to community hospitals sometimes. The science says 80% of people will go to the closest hospital. They may need redistribution to specialty centers. And again, if you have 1 or 2 or 3 potential receiving centers, often it's very hard to, in real time, figure out the capacity and the capabilities of those centers and get patients to the best destination. Hospital evacuations, they happen because of wildfires, they happen because of flooding, they happen because of hurricanes and other reasons. And if you have especially multiple hospitals evacuating at once, trying to match the patients to the best clinical capabilities in the receiving hospitals is really, really hard. Again, we don't typically have any unifying system for figuring out all the patients that are evacuating. If, say, there are 2 or 3 hospitals threatened by a wildfire, find all the receiving beds and then put the highly specialized or the most complex patients in those rare specialized beds, figure out best how to move the other patients around so that we use our resources best. There are circumstances where we repatriate Americans overseas with conflict or war fighters from the military. Many of you know that the US military has been downsizing its medical footprint. And if we have to find the best way to take care of soldiers, sailors, airmen, others in our hospital on the civilian side, we want to make sure we're using our resources best there. And of course, we've all been through the COVID-19 pandemic, and it's pretty well known, I think, probably to everybody watching this webinar, how we didn't always as a country make use of our available critical care, other inpatient resources equally across communities. Next slide. So what's the value of regional structures? Well, then it's to bring the right people together. And a lot of what Shelley and I talk about frequently is our role as conveners. And we can bring together local public health planners, local hospital planners, along with state public health counterparts, and even folks across the region to make sure that regional disaster medical capabilities are equally available to those even across large distances. It's often really hard in the governmental world to create medical disaster plans across state lines because of just the way our governmental system works. And one thing we can do again is convene people, bring like-minded people together to help create plans across state lines where disasters often spill across geographic boundaries, especially when we're talking about moving patients to specialty care. We can create better partnerships, make sure that we have good communications, we speak the same language, we share good data between those healthcare facilities that have disaster medical capabilities and those that maybe don't have as many capabilities, right? We want to make sure that those that are a little bit bigger can leverage their resources to help those smaller community hospitals who are often really stressed in so many different ways and improve their readiness. Next slide. So what is the RDHRS? Why do we exist? Where do we sit within ASPR? And I think Shelley and I will both be careful to point out we are clearly not speaking for ASPR, right? We are just individual leaders of our programs, but we are funded by ASPR, the Administration for Strategic Preparedness and Response within the U.S. Department of Health and Human Services. And ASPR is, of course, responsible for supporting the healthcare readiness of the nation in so many different ways. Along the left side of the slide, you see that there are a whole bunch of programs, a whole bunch of activities that they have. And probably most of you are familiar with most of these, but there's the hospital preparedness program. There's the National Special Pathogen System that is being developed by the National Emerging Special Pathogen Training and Education Center and others. There's the National Disaster Medical System. There are lots of programs and resources within ASPR. However, in 2018, ASPR also rolled out this new initiative, the Regional Disaster Health Response System. And it was to try and address some of those gaps that we just went through, to identify and address problems in coordinated patient care, surge, specialty care in disasters. And we are a key partner with the National Healthcare Preparedness Programs, the NHPP. And the idea is that we serve as a tiered system. So regional centers of expertise, folks that really focus a lot on medical and healthcare disaster planning, like the University of Nebraska, like Massachusetts General Hospital, the host programs of the RDHRS sites. And that we work with our state public health partners, we work with coalitions, we work with hospitals directly, as well as with others across the private sector and government. So obviously others within HHS, but also our FEMA partners to try and improve overall regional readiness to be able to take care of a large number of patients in a disaster. Next slide. So there are currently 4 programs. The Nebraska program, which Shelley leads with Dr. James Lawler, and the Massachusetts program, the Region 1 New England program that I lead with Dr. Eileen Searle. We were the original 2, but we were really, really excited that we've been joined by 2 more programs. One in Denver that was awarded in 2020 in the Denver Health and Hospital Authority. And our newest RDHRS site, the Southern RDHRS, based at Emory Hospital in Atlanta, which was awarded in 2021. You can see, what we are designed to do, and I think again, it's representing the voice of healthcare delivery and healthcare operations. It's trying to convene and align plans and resources, trying to overall improve our response capabilities, especially our surge capabilities. The last 2 bullets there you can see on the lower right, trying to figure out how we measure preparedness, one of those incredibly challenging questions in our field, and how do we prove that we're making a difference? How can we demonstrate that this is actually making us more ready? And that's through tests in exercises, but also in real world events, which is why we're going to talk to you about the triple-demic a little later. Next slide. So what are some of the core functions that we as RDHRS programs have undertaken in support of this mission? Well, the first is that we are trying really hard to recruit a greater number and a greater variety of healthcare disaster experts to participate in disaster planning. This means our pediatric intensivists, this means our burn surgeons, trauma surgeons, emergency physicians, our nurse leaders focused on disaster preparedness. And have them really give good input into disaster plans so that they represent the real world way in which our healthcare system works and the way in which institutions work together. We tried to provide support for exercises to make sure those exercises are realistic, that they're conducted well and really test our capabilities, and that we evaluate them well with, again, the right experts who can look critically at exercise participation and make sure that we find those things we need to improve. As I said, we want to improve overall just our SME, our subject matter expert participation. We want to make sure that both in the planning phase, but even during response, we can mobilize those subject matter experts to provide their expertise. So if, God forbid, there's a large-scale radiation event, there are lots of radiation resources, but many of our hospitals have medical radiation experts who can help advise and provide real-time feedback during response. We are really focusing a lot on patient movement. Again, right hospital, right for the right patient at the right time. And that's because our systems are so constrained in every way, as everybody probably watching this webinar understands. In a disaster, we don't have a lot of excess capacity. We need to make sure that the people we send to different kinds of hospitals with different clinical capabilities are the most appropriate to those for those hospitals, or if patients self-present to those hospitals, which they often will, that we can help with redistribution, help us as a community respond most effectively. Next slide. Everyone is focused on situational awareness, rightly so, as one of the most important things we all need to do together during a disaster. But I think particularly from the healthcare side, there are certain variables, there are certain data points that matter a lot more to hospitals and hospital leaders than maybe others elsewhere in the response. And so really trying to figure out what those data points are, share data on that so that our CEOs, our COOs, CNOs, CMOs make really good decisions, both when designing disaster medical systems and operating them in real time. We try very hard to be hubs of training and education. So grateful for the Region 7 RDHRE for this webinar program, for the training that they do. We try and identify those legal obstacles, those challenges when we cross geographic boundaries that sometimes make it hard for us to respond together. We're trying to help support different hazard-specific plans. So as many of the coalitions have really been focused on radiation plans, chemical plans, burn plans, pediatric plans aligned with the federal effort, we try and make sure we help support those coalitions with aligning their plans so that, again, you don't find one state having a plan very, very different or competing with resources from another state. And lastly, we'll just say during disasters, we do our very best to augment the capacity of the system. And that's through a wide variety of resources. Some of us have deployable disaster medical teams that are available. We have access to telemedical capabilities. And we'll say a little bit more about telemedicine later. Next slide. So, again, this is just one program within HHS and ASPR. One more time, I clearly can't speak for them, but they really see there's so much value in partnerships with everyone else because again, everyone watching this webinar, I'm certain, knows how collaborative we have to be in our emergency planning and in our response, and that goes from the private sector to the federal level to state, local, tribal, and territorial partnerships. Everyone really has to come together for us to be able to plan and respond together effectively. Next slide. So just a couple of numbers, and now these are actually getting a little bit out of date. This slide's almost a year old now, but we have just in our programs more than 75 partnerships with governmental agencies, hospital associations, others. We did a survey just to see how what our partners thought of us, and really pleased to see that nearly 90% thought that the RDHRS was a helpful entity to be improving disaster healthcare preparedness and response. I mentioned that we're trying really hard to develop toolkits, educational resources, trainings. We've actually created more than 50 different toolkits and trainings, and that number is now actually substantially larger over the past year. We'll talk a lot about our pediatric response, so I won't go into that, but we've had also more than 2,000 hours of training just by Shelley's Region 7 RDHRE alone. That's one of the 4 programs. And so as our role in our regions around the country, conducting training, promoting disaster-specific, hazard-specific education, really trying to improve the readiness. I think we're really proud of what we've been able to accomplish since this program was first created. Next slide. Oh, sorry, we can go back one. So this is just a slide on kind of where we've been and where we're going. As I mentioned, Shelley and I, our programs were the first 2, but we have been expanding. And of course, somewhere along this timeline, meaning specifically starting in 2020, COVID happened. And although the original RFP, the original proposal for the program, was not to have us quickly turn into response-oriented entities within the first 18 months of our existence. I think everyone would have had questions if we didn't participate in the response 18 months in. And we're really pleased that we'll tell you more about this in a bit, but that both of us were able to take what originally were capacity building, almost demonstration project kind of structures, and pivot them into real operational response structures that helped improve disaster response, so the response to the COVID pandemic in both of our regions. As we now are coming out of the COVID pandemic, we really are continuing to find new ways to take on new challenges. I think we both were able to leverage a lot of our lessons learned from COVID and help accelerate the response to mpox in our regions. And now the four of us, the four RDHRS sites, are really working well together. As we'll say at the end, we're very eager, hopefully, to have the other 6 federal regions join us as soon as possible in this program, so that we can really develop a nationwide system of RDHRSs covering and supporting the country. So with that, I think I'll turn it over to Shelley for the next portion of the webinar.
Great, thanks, Dr. Bittinger. I feel like we could both speak to so many examples, and unfortunately, this is only a short presentation today. We want to leave lots of time for questions too, and there's some really good ones in the chat so far. So next slide, please. So as Dr. Bittinger talked, one of our biggest roles is serving as a convener. It was like very eye-opening to me. In year 1, we both sort of focused on our own states. And there were lots of different groups doing lots of meaningful work, but really, to say that they each knew each other or knew what was being worked on or had, alignment in order and focus, etc., is an understatement. That just wasn't quite there. And then really in years 2, 3, and even through COVID, 4 and 5, we've really expanded now robustly to our regions. So when I think about, ways that we've served as conveners, we've each got specialty teams for most of the hazards. And those specialty teams are made up of unique individuals with subject matter expertise, such as when we talk about radiation, we've got, state-based resources, radiation experts. We've got radiation experts in the healthcare facilities. We've had co-leaders from different states come together, help coalitions sort of parse through how to create that annex to be really meaningful with those Region 7, in our example, resources and expertise that exists. Same thing for chemical through the poison centers, advancing education and training in the region. And then as we look at Region 1, some of the specialty teamwork that went on there, particularly in COVID, really helping from a medical operations sort of coordination to help get ventilators from the Strategic National Stockpile dispersed appropriately within the region. With equity and knowledge and prioritization and triage of that, as well as some telemedicine resources to support critical care delivery in the New England area as surge was happening. So as we think about sort of the future of being conveners, another couple of examples from Region 7 are we have 27 healthcare coalition coordinators that convene with us once a month. And we really work collaboratively with them to really broaden their knowledge of who each other is, what each other is working on, share best practices, convene on a certain topic of interest, push education and training materials, and just overall, building a cadre of individuals that if something happens in one state, the others can step in, help, reach, through the coordination of the region, leaders, etc. So that's one example. And another would be, really the trauma folks. So again, great example of having a lot of really purposeful professionals, but do they really coordinate, collaborate in a purposeful, meaningful way as a state, number one, but number two, as a region, so that we know each other, right? If there is a large scale event in one state or another, we can help each other out and quickly be agile in that coordination, especially in those early days and hours until federal support can come to be. Next slide. A couple of other examples. I talked a little bit about the Medical Emergency Operations Center concept. So really making sure that we have close coordination and communication, sharing protocols, templates, toolkits, little bit of level loading during COVID for sure, to support the larger whole, particularly in Region 1, And in Region 7, really implementation of a bed dashboard that hopefully could drive situational awareness around bed capacity as it relates to staffed beds, which we know is really the ultimate with our workforce challenges. And then how does that connect to the health information exchange to have real-time information? And now we're really pushing to make that a regional effort as well. So nothing like that really exists. Next slide. So I'm going to talk just briefly about the triple-demic and some of our experiences here in Region 7, and then I'm going to turn it over to Dr. Bittinger to talk about the Region 1 experience. So back last fall, early winter, had a couple of hospitals in Region 7, one from Missouri and one from here in Nebraska, reach out and say, you know, things are really tough and we need some help. And they knew about the RDHRS from presentations that we had done. So we quickly were able to convene 22 hospitals here in the Midwest who care for kids. Number one, they didn't really know each other, so that was good in and of itself. Number two, it gave us a forum to do bed capacity reporting. We were doing it daily for a period of time. And then as things subsided, we were able to ease that out to be every 2 weeks and then monthly. And be able to also, during that really significant surge period of time, make sure that we were providing education and resources in a just-in-time fashion to those pediatric providers and clinicians out there on the front lines. They were able to see where beds were available in Region 7. They were able to connect to those transfer centers. We also brought together the transport teams. So typically in the world of kids, you know, it's this linear process, right? So if we're getting a kid from over here, we're going to go get them ourselves, bring them back to us. Well, time is of the essence, right? When you have a sick kid. So knowing what that all looked like, it might have been quicker to have somebody out of Kansas City Children's go get the kid, get them back to Nebraska or wherever. So we still have this relationship today. And in fact, we just met again this morning. Things are starting to tick up. And so that team has asked that we meet every 2 weeks moving forward until we see what this year's RSV influenza season is going to look like. So that's just one example of many to share with you all. Next slide. And this again is just another example of where we've got all these partners now. Everybody knows who each other is, can reach out, and then we can quickly convene if need be. Next slide. Dr. Bittinger, I'll let you talk about the Region 1 PEDS experience.
Thanks so much, Shelley. Yeah, so a lot of what we did is very similar to the amazing work that Shelley and her team did in Nebraska. You know, in Region 1, the New England region, which is, again, I think similar to probably what all of you experienced, the access to ICU beds was just really constrained, and not every child who normally would have gone into a pediatric ICU with positive pressure ventilation or high flow oxygenation could do so. We just didn't have the beds. And so we pulled together experts from Mass General Hospital, from Boston Children's Hospital, from Yale New Haven Hospital, from the University of Vermont, pediatric critical care centers across the region to put together a webinar series. And you can see the topics listed here. And we had hundreds and hundreds of attendees helping to learn how they could safely provide some higher level therapies on the pediatric floors, because that was really what was necessary. So high flow nasal cannula, some really focused education on the entity of bronchiolitis, positive pressure ventilation, airway management. And I'm really pleased that we included, as Shelley mentioned, patient transport. Our transport teams were there as well, because, you know, for us, and I expect for all of you, critical care pediatric transport is a very scarce resource. And so oftentimes we had our paramedics, our ALS services, transporting some pretty sick kids, and they were trying to figure out what they could and couldn't do to safely move children around. So these webinars are still archived. They're still available if anybody wants to view them now. We certainly are hoping for a milder RSV season, but none of us knows what's coming. And we will keep those trainings up. Next slide. One of the other things that we are really, really proud of, it aligns with what Shelley mentioned previously, is up until last year, there really was no single source of information to identify all of the hospitals that had inpatient pediatric care capability and which ones had pediatric ICU capability across New England. Seems like that should have been something easy to find, but it wasn't. And we were really excited that all of those sites were willing to come together to collaborate on a single tool. We called it the Pediatric Transfer Availability Coordination Tool, or PDTRAC. And what it was first off just a listing, which many people found really helpful, just to have as a list with phone numbers and contact information. But we asked the centers to give us a stoplight, red, yellow, green summary of their status with respect to accepting transfers. So red was, don't call us, we can't take a transfer, we clearly can't do anything. Green was open, and there, as you would expect, was not much green. But then there was yellow, and yellow with commentary. And what it did is allowed providers who were in the community or in emergency departments who had a sick kid they needed to get to a specialty hospital, say inpatient pediatrics somewhere, to be able to make fewer phone calls to be able to find the right bed for their patient. We had more than 200 users register for the tool. Most of them were hospital-based. We did offer access to our coalition and public health partners. And we've had a tremendous amount of positive feedback from specifically the emergency medicine community, but others as well. And I think it was a nice demonstration of the fact that you can bring people together, share information, and do it in a pretty low-touch version. Each of the pediatric hospitals was asked to update their color coding capability twice a day. On average, it took less than 30 seconds for them to do so. And we had really good compliance with people keeping their status updated over the course of the tools being live. So as the surge passed, we've now taken down the tool, but as we continue to think about other ways in which we can support more efficient patient movement, especially during disasters, we think there's a lot of good lesson in here. Next slide. So as I mentioned, we are trying to keep these resources available. Our website for the Region 1 RDHRS is rdhrs.org. You can go look at the tool. You can look at all of the previous webinars, and frankly, we're both Shelley and I will offer our programs contact information. Going forward, if you have other areas where you think trainings or focused resources would be available, we really, really always want to hear from our partners and would welcome your suggestions. Next slide. So where do we go from here? Next slide. So I already alluded to the fact that only 4 of the 10 HHS regions in the country have RDHRS programs. We clearly are pretty biased on this one, but we think we add a fair amount of value. We were very proud of what we've accomplished. And it would be much easier as a country to talk about where RDHRSs fit into the national conversation of healthcare readiness if everyone had one. It's a lot harder when not everyone has the same resource. Again, we weren't originally funded to be response entities at all, but we pivoted to do so during COVID and continue to do so, as I said, through the monkeypox outbreak, through the RSV tripledemic. We even were really pleased to have conversations with our regional ASPR partners in the tragic Maine shootings recently. And it's another example where potentially, and in this case, we didn't need to take action to support that, but potentially patients would have to move around across the trauma system, and being able to connect trauma centers across multiple states is an important capability of an RDHRS. So we're very proud with what we can do, but we are not really funded like a 24/7, 365 response entity. And ultimately, I think is another step in the growth of the programs. Together, ideally, all 10 of us would start to figure out what that takes to be able to mobilize resources. We are very proud for the Region 1 RDHRS. We have a 24-hour duty officer that can be accessed by any of our state public health partners. We can turn our resources on 24/7, 365. So we do try to maintain that level of readiness, but nothing is sitting sort of in a warm state. It has to be started with the phone call and mobilized only once that phone call starts. Lastly, you all know this, everyone watching this webinar understands the fatigue and the resource constraints in the healthcare system. As much as we have had extraordinary participation from all of our partners in healthcare, from the other hospitals, EMS systems that we are working with, they are all tired, they're all facing budget constraints, and they all have very big operational challenges. And so trying to have one more thing to do to partner with an RDHRS to improve disaster preparedness is not always at the top of everybody's list. And so I think I'm hoping, I don't want to be, unrealistically optimistic, but over time, as we get back to a new normal in healthcare, maybe that will get a little better. But I think we're going to continue to rely on the goodwill and really just the extra effort from those who understand the importance of collaborative planning for disaster response. What are the opportunities? Where are we going? I'm just going to list these 3 bullets and turn it back to Shelley for closing remarks. I think we have heard again and again that a lot of what we've been able to do is helping healthcare organizations respond to some of their biggest threats. Shelley and the Nebraska team have prioritized cyber attacks as one good other example of what we are trying to work on. We know that healthcare has rapidly now become one of the most attacked sectors, business sectors in the entire country. I think we need to show that responsiveness as RDHRS centers. We have so far, and I think we will continue to do so. That will, I think, keep us in the conversation. We always want to prioritize our resources and our actions to what you need, and it's why, again, I would welcome everyone's suggestions for where you think gaps exist or where resources are needed. And for those of you that are in either my region or Shelley's region, we continue to invite you to reach out to us and tell us how we can be helpful. And really, I'll close with just, I think one of the most important things we do is advocate as the voice of healthcare expertise, disaster medical expertise in disaster planning and response. What motivates the healthcare world, how we work as a sector of the economy, how we work together or don't work together during response, that requires a lot of knowledge of really intimate knowledge of how healthcare organizations function. And I think we're really pleased that that's what we're able to represent. Bring subject matter experts to the table, understand really what CEOs do and don't value when they talk about planning, understand how best to work with coalitions, with state public health partners, with federal partners. It's that ability to understand and represent the needs of the healthcare system that I think has helped us to achieve what we have so far. So Shelley, let me turn it back over to you for wrapping up, and just want to thank everybody for joining us.
Yeah, thanks, Dr. Bettinger. I think the only thing I would leave you with, and we're going to get to the questions here in a couple of moments, some really good questions, is that we're better together, right? So I think, there's been please don't think that this is replacing anything. I would like to instead encourage us to think about it being sort of some additional glue to bring the right partners to the table and make sure that we're looking beyond our county, beyond our coalition, beyond our state, beyond, our region. Even if we need to go region to region, eventually that would also be, another opportunity for us. And definitely partnering with our federal partners, definitely partnering with our state public health, our state emergency management, our county level partners in those same groups, but also our coalitions, right, which is made up of all those partners. We just have seen such a phenomenal advantage of really pulling all of those people together in a purposeful way. And I think, as Dr. Bettinger said, I'll just be honest, I felt like, even though I've been in healthcare for 40 years, that there were really some pretty significant gaps where healthcare was not at the table. For a lot of disaster response pieces. Granted, we take the incoming and things like that when there are injuries or other hazards that need medical care, but really there's a lot of expertise there that can be brought to bear. And I think, augmenting that piece has been a big part of our response as well. So I want to transition to a few of the questions, which I thought were really, really good. So one of the questions, and Dr. Bettinger, you may have some thoughts on this too. I'll start with is this model a similar model to the RITN network of hospitals, which for anybody who doesn't know what RITN is, that's the Radiation Injury Treatment Network. There are about 70 of those designated hospitals across the country. It's a response capability that those of us who are RITN hospitals raise our hand and say, yep, we know that we could help care for patients with radiation injury and exposure. We could do laboratory testing for outpatients. We could do bone marrow transplant if we absolutely needed to do that for significant radiation exposure. And we want to be part of the national response for some sort of large scale event. I feel like that's a little bit different than the RDHRS model, which is really a regional model. Because the RITN network is really a national model. So if something were to happen on the East Coast, it's very possible that my hospital could be asked to activate, right? So they may move patients from there to here to get outpatient laboratory consecutive testing, to get bone marrow transplant if needed. It all depends on the scope and the scale of the event and then some adjacencies. So all in all, it would just depend, right, on what was asked of us. So Dr. Bittinger, I would say it's not really like the regional disaster grant. It's more of a national response, but there's like 70 hospitals who contribute to staying ready for that sort of raising of the hand to say we'd help.
I think that's right. I think, you know, the RITN centers, there's an element that is similar, which is they have a certain capability that can be useful in disaster, and they've raised their hands to say that they can help. But number one, kind of, you know, it's focused obviously on the area of radiation hazards and not set up with really a regional responsibility, but just as, you know, raising hands for a capability. And one of the things the RDHRS programs have been given is a responsibility to look across their whole region and try and make sure that they have partnerships, plans, and response structures to support the region. And again, we by concept are an all hazards entity. So we certainly would work with the RITN as well as, of course, with our state public health partners and our federal partners in a radiation incident. But we would work with NETEC and those same other partners in a biological incident. We would work with always the right subject matter experts within the response to any kind of incident, no matter what the hazard.
Thank you. The next question says, is there a set definition as to when a region would step in on a mass casualty incident? An example might be an active shooter at an event in downtown Omaha with, let's say, 19 injured. Since it's only impacting Omaha, would the region come in? And my response would be, it depends. So there's a whole lot of things that would go on with an event of that level. As we know, and Dr. Bittinger mentioned how full hospitals are today, right? So we would hope we'd be able to slow things down in surgery. We'd be able to triage people accordingly to be able to accommodate 19, here in the Omaha Metro between the trauma centers for sure. So I think, I would say probably not, but you never know, right? But if let's just say it was kids and we're in the midst of RSV season, would we need to transfer maybe one of the children injured to Kansas City? Maybe. So while it may not be a whole of region approach, we have the relationships now to make those things happen in a very timely fashion should the need arise. Same thing with a burn type event. We now have good clarity about where are the burn centers in our region, which that is not the same outline of states that's in most of the other regional approaches. But having some clarity about that and having done some work on that, that becomes a little bit clearer. So the answer is it just depends on the type and the scope and the acuity of the event and the available capacity of clinical expertise. Anything you would add? Dr.
Yeah,
Green?
I would emphasize something you said earlier, which is we are also committed to working well with our partners and to adding value, which means not duplicating existing structures or not conflicting with them. And so we would only be involved when invited by our state public health partners. So we don't automatically enter a response unless we've been formally requested, because again, we don't want to step on any of the areas of responsibility of coalitions of state public health partners. We think there's obviously a lot of value there, but if we self-deploy, there'd be a risk of that. So we work very closely with our ASPR regional staff, with our state public health partners, and I think it really would be depending on what the state felt was a need from our perspective and whether they wanted to ask for our assistance, exactly as Shelley said.
All right, the next one is how are the RDHRS regions interacting or interfacing with the Pediatric Disaster Medical Centers of Excellence that are also ASPR funded? And then I might also put in there the ones that are funded by HRSA, right? The Pediatric Pandemic Network and others. So the answer is we are. So for example, this morning on our pediatric call, we had individuals from both the Centers of Excellence for Pediatrics as well as the Pediatric Pandemic Network. And in many cases, those folks are also participating as our Region 7 pediatric leads. So what we're doing is we're not duplicating efforts. Instead, what they're bringing is the information from those other grant works and then applying it in Region 7. So we had a whole slide full of expert resources that are available now. We're not redundantly creating those. So we're leveraging and optimizing these other grants to really bring those to fruition. We're doing that in NETEC too, from a standpoint of biological and infectious disease work. So Dr. Bittinger, anything else?
Nothing much to add, but for those of you that do look at our pediatric resources from the triple-demic, we were very excited to post a lot of the resources that were coming out of those pediatric centers of excellence. It was good collaboration.
Thank you. Dr. Bittinger, I'll give you first up on this one. What about rural critical access facilities? How fast can we step in to assist, and what's sort of our role and responsibility there?
I think, a few different things, especially, but both of us feel a strong responsibility to those hospitals that are critical access hospitals, the ones with the least amount of support around them. I would say right now for critical access hospitals, if you have education, training, planning needs, reach out to us directly. I can't promise that we can honor every single request, but we will do our very best to help because we know how thin sometimes the resources can be in that setting. In terms of an actual event, once an event happens, we again don't want to get in the way of the usual response with the lowercase r, the region or coalition going up to the state. But as soon as the state makes a request, again, we have a 24-hour duty officer. We can try and see what resources we can have. It may be a deployable medical team. It might be telemedical resources. I will point out that during the COVID-19 pandemic, one of the things we did through our program is mobilize critical care telemedicine resources to be able to support the ICUs that didn't have intensivist coverage overnight. For a no-notice event like a mass casualty event or a severe weather event, maybe a tornado, again, once activated, we would work to help find receiving destinations for the patients that need to be evacuated. If patients need to be cared for in place while we're mobilizing EMS resources, telemedicine is another possibility, support for trauma resuscitation, support for others, but it really would depend on the specifics of the incident.
Thank you. And in Region 7, we are predominantly rural. So all of our coalitions in Region 7 really touch areas of rural locations. So we definitely have pulled them in. We've provided education and training out in some of those rural areas, and we are open to doing more. So just encourage you to go to our Region 7 website, and we'll make sure that, I think that's on our last slide actually in the deck. So both of our websites. So thank you for that. Then let's see. I think a couple of comments just about the value being leveraged is the expertise that's available, not just in healthcare, but public health and emergency management. Could not agree more. And we certainly use the chain of command. So that needs to start local, as we all are very clear about, and then go to the state and then beyond that. So really working through a lot of those logistics and being really clear on that. Particularly, we've worked a lot with NEMA on our specialty teams, and that's our Nebraska Emergency Management Agency. And then Kim says, how does your response change in Region 7 for the more rural areas versus the urban areas within our region? And just very similarly to that, just, you know, our effort overall is that, you know, I've grown up in rural Nebraska my whole life, and I know how people just come together, right? So that's sort of this whole of community approach, the ecosystem we're trying to build about resilience and having the education and training, the stop the bleed, all the basic principles of doing what we need to do, right, to save lives quickly, and then understanding what are my additional resources. So when healthcare gets saturated, then where can I go next? And then what's next after that? And really doing our job to kind of put all that together and better understand how do we access some of those volunteer agencies. Then when we get bigger, how do we access, you know, the specialty efforts? And then obviously our federal resources then are in line to eventually provide that support and leverage too. So I think that looks like all of our questions. So we're getting close to our time. Anything else you would add, Dr. Bittinger?
No, maybe just one comment. I think, you know, we're really obviously all across the country grieving, but particularly here in the Northeast after the Lewiston, Maine shootings. What we saw in that experience is exactly what you would expect and probably what you all have seen in different tragedies. Everybody wants to help. Everybody wants to offer resources. Everybody wants to come together. But we don't always have the right structures and mechanisms. And I'm not referring to Maine when I say that comment. It's just that as we surge and get more and more healthcare organizations, when we're really trying to use our clinical capabilities, that's where sometimes we falter when we have lots of different healthcare systems or healthcare organizations, and we have lots of state lines, and we have lots of different capacities. And part of what we are really trying to address through the building of an RDHRS, RDHRE network is a superstructure, a way for people to come together efficiently, use all of their resources, and we do what we do, which is save the most lives and protect health the most. So we're really, really, really grateful for everyone attending today. I just want to say thank you. I welcome your thoughts, suggestions, questions. All of it's welcome. And Shelley, let me turn it back to you and we'll wrap up.
Could not agree more. And as you can see, we pretty much, you know, work a lot together too. So we're really hopeful that as time marches on here, we'll get additional regional disaster hubs across the nation to be able to connect more purposefully too. Wouldn't it be nice someday to be able to go over here or over here and even grab more help and assistance if needed? So with that, Thomas, I'll let you kind of talk about continuing ed one more time and sort of how we restructure the next step here for folks.
Sure. First and foremost, though, of course, I want to make sure we thank everybody for joining us today. Contact information for both of the regions right here, as well as our website, if you guys would like to do that. I believe Mark has just put in the chat some information about it, as well as I have the slide here for you all for anybody who's going to be doing our continuing education. Other than that, unless there are any other questions that anybody has, we appreciate you coming, and it looks like we will give you 1 minute back of your day.
Thank you everyone for attending.